Welcome back to the deep dive. Today, we are taking on quite a task. We're essentially mapping the entire lower half of the human body.
But through the lens of radiography, right?
Exactly. We're
Yeah.
looking at the blueprint for imaging the lower extremity. Think all the rules, the angles, the precise positioning needed for everything from, the tiny toe bones right up to the femur.
Right. And our sources give us this incredibly comprehensive guide. It details all the essential projections. But like you said, we're not just listing things off.
No.
Our goal here is really to unpack the why. Why these specific positions? Why these specific positions? Why these CR angles, that's the central ray, and crucially, the evaluation criteria. How do professionals know they've actually got the perfect shot?
That's the key, isn't it? Because if you're off by just a little bit, the image could be useless. Or worse, it could hide something important.
Absolutely. A misfracture, a misdiagnosis, it all comes down to that initial image quality.
Okay, so let's start right at the bottom, foundationally. Before we even talk about angles and views, what are the absolute must-know bits of anatomy for the foot and ankle?
Well, there are two quick ones that really anchor everything. First, you've got the talus.
Okay.
That's the tarsal bone, one of the foot bones, that actually connects with the leg bones, the tibia and fibula. It forms the main part of the ankle joint. Understanding where that sits is just central.
Got it. Talus connects foot to leg. What's number two?
The calcaneus,
Yeah.
your heel bone. And the key thing here is that it's the largest of all the tarsal bones.
Ah, okay.
And its size and how it sits sort of vertically means it needs some pretty dramatic angles when we image it actually, as we'll see. Knowing those two, talus and calcaneus, it sort of grounds you before you start twisting the foot into position.
All right, grounded. Now let's talk procedure, the sort of bedrock rules for any good radiograph. Before any x-rays fly, there's patient prep. And artifact removal sounds basic, but it's really a zero tolerance thing here, isn't it?
Oh, absolutely critical. Mandatory, really. Artifacts, basically anything showing up on the image that isn't supposed to be there, can look exactly like a problem or hide one.
So what needs to come off?
Shoes, obviously, but also any clothing over the area. And the sources are really specific about socks or hose, especially if they have elastic bands.
Why elastic?
That elastic can show up as these dense lines or weird shadows. It can mimic soft tissue calcification or even look like a foreign body fragment. And heavy stuff like denim jeans, thick seams, rivets, that has to be rolled way, way up, completely out of the way of the part being imaged.
Wow. Never thought about a sock seam derailing a diagnosis. Okay, artifacts gone. Next up, positioning.
And this changes immediately based on whether the patient can walk, right?
Yep. We basically split them into ambulatory and non-ambulatory. If the patient is ambulatory, can walk, it's usually pretty straightforward.
How so?
They can sit on the table, maybe lie down supine. The affected leg or foot just rests right on the image receptor, the IR, which is usually flat on the tabletop. Simple enough. But what about non-ambulatory folks? Wheelchairs, stretchers, people who can't move easily.
Yeah, that's where you really have to adapt. For these patients, the priority is comfort and, crucially, not making any injury worse. So the big takeaway here is you don't necessarily have to transfer them from the stretcher onto the x-ray table.
Really?
Yeah, often it's safer and better to leave them be. The radiographer then adjusts the equipment, maybe brings in a portable x-ray unit, or just angles the tube differently to get the shot while the patient stays put on the stretcher or in their chair. It's all about adapting safely.
So the tech becomes a bit of a problem solver on the fly. Okay, patient's positioned. Two more mandatory things, ID and safety. Let's hit ID markers first.
Non-negotiable. A clear R or L marker for right or left must be visible within the exposure field when you take the picture.
And it has to be a physical marker.
Absolutely. The sources are very strict here. You cannot rely on adding it digitally afterwards with annotation software. That marker needs to be physically on the IR cassette during the exposure. It's fundamental to preventing really serious errors, like operating on the wrong limb.
Yeah, makes sense. Okay, and the other cornerstone, safety, radiation protection.
Two main things here. First is collimation. Really tight, proper collimation.
What do you mean?
Making the x-ray beam only as big as the specific area you need to see, nothing extra. This cuts down scatter radiation massively, reducing the dose to the patient.
Good. And number two?
Lead shielding. You always place lead shielding strategically between the x-ray source and the patient's gonads. Minimize that reproductive organ exposure.
Right.
And one final point, specifically for the distal, stuffed toes, foot, ankle. You don't need breathing instructions like you do for chest x-rays. But telling the patient to hold perfectly still is absolutely critical. Any motion blurs the image, and you can easily miss a tiny fracture line.
Okay, let's zoom in on the very end. The toes. Now, you'd think a straight-on AP shot would be fine, right? But the sources immediately say AP axial. Why the angle? Why complicate it?
It seems like complicating it, but it actually simplifies the diagnosis. A
Hmm.
standard AP view, straight on, causes two problems. First, foreshortening.
Makes the bones look shorter.
Exactly. Squish, like you said before. But more importantly, the joints overlap. The spaces between the little toe bones, the IP joints, and where the toes meet the foot, the MTP joints, they just get superimposed.
Ah, so the angle fixes that.
Right. The AP axial projection, by adding that angle, lines the CR up better with the long axis of the bones, and poof, it opens up those joint spaces beautifully. Critical for seeing things like early arthritis or tiny chip fractures right at the joint line.
Okay, so what's the magic angle, and how do you actually achieve it? Tube angle, wedge.
The standard angle for toes is usually 15 degrees posteriorly. That means angled towards the heel or caudad. And you center the beam right at the third MTP joint where the middle toe joins the foot.
And if the machine can't do that angle easily,
Great alternative. Keep the X-ray beam perpendicular, straight down, but put the patient's toes up on a 15-degree wedge sponge. Elevating the toes physically achieves the exact same geometric result. Opens those joints right up.
clever, huh?
Very clever. A low-tech fix for high-tech imaging. Now, getting a lateral view of just one toe, that sounds fiddly, they all bunch together. How do you isolate just one?
It takes some careful work. Immobilization is key. For the big toe or the second toe, they're a bit bigger, so you often use gauze. You sort of pack gauze between the toe you want and its neighbor to physically separate them.
Okay.
Then you might tape the other toes down, flacked out of the way. For the smaller toes, 3 through 5, you might use tape or another immobilization device just to hold that one toe perfectly sideways, isolated.
And the X-ray beam goes where?
Perpendicular, aimed right at the PIP joint, at the proximal interphalangeal joint, the middle joint of that specific toe. The whole goal is zero overlap from the other toes. You want a clean profile. Makes sense. Now, what about those really tiny bones near the big toe, the sesamoids? You need special tangential views, right? Lewis and Hawley method.
Exactly. Sesamoids are these two little pea-sized bones embedded in the tendon under the first MTP joint, the big toe joint.
Yeah.
They can cause pain, get fractured. So you need to see them clearly, away from the main bone.
So how do Lewis and Hawley differ in getting that shot?
It's mainly about patient positioning. The Lewis method has the patient put their big toe down on the table, pulling it back towards the shin as much as possible. That's dorsiflexion. The ball of the foot ends up perpendicular to the table.
So the table helps hold the position.
Right. The Hawley method is usually done seated. The patient has to actively flex their toes, curl them under, and then hold them there, usually pulling back with a strip of gauze or tape. It's a bit harder to hold.
But the beam is the same for both.
Essentially, yes. The CR is perpendicular to the IR, but aimed tangentially to the ball of the foot. It sort of skims underneath the first MTP joint to throw the sesamoids into profile, clear of the metatarsal head.
Okay, moving back a bit to the main part of the foot. Again, AP axial, not just AP. Why the angle here? It's 10 degrees this time.
Yep, 10 degrees posteriorly towards the heel. Same reasons as the toes, really, just applied further back. It tackles foreshortening of the metatarsals, the long bones of the foot, and crucially, it gives a much better view of the tarsometatarsal joints, where the metatarsals meet the tarsal bones in the midfoot.
And without that angle.
Those TMT joints just look like a jumbled mess of overlapping bone edges. The 10-degree angle opens them up. You center it at the base of the third metatarsal.
Got it. Now, oblique views of the foot. Rotation is needed. 30 degrees, the sources say. But does it matter if you rotate the foot inwards medially or outwards laterally?
Right. Oh, hugely. The 30-degree rotation amount is the constant, yes.
Yeah.
You lift the side of the foot so the sole, the plantar surface, is 30 degrees off the IR. But which side you lift completely changes what you see clearly.
Okay, break it down. Medial rotation first.
Medial rotation, turning the foot inwards, that primarily frees up the third, fourth, and fifth metatarsals from overlapping each other. It also nicely shows the base of the fifth metatarsal, the outside one. That's important because of Jones fractures, which is for there.
We'll come back to Jones fractures, I bet. So medial for the outer metatarsals. What about lateral rotation?
Lateral rotation, turning the foot outwards, does the opposite. It separates the first and second metatarsals, the ones on the inside, near the big toe. So, you see, the choice isn't random. The doctor suspects a problem with the fourth metatarsal. You do a medial oblique. Problem with the first. You do a lateral oblique. The view follows the suspected pathology.
Makes perfect sense. And quickly, weight-bearing views. Why stand someone up for a foot x-ray?
Because feet bear weight. Standard x-rays show the bones, but not necessarily how they behave under load. Weight-bearing views, both apiaxial and lateral, are essential for assessing function.
Like arches collapsing.
Exactly. Things like flat foot, pes planus, or other structural issues related to the arches might look totally normal in the patients lying down. But have them stand, put their weight on it, and suddenly you see the collapse or the deformity. For the apiaxial weight bearing, you still usually need that 10 or maybe 15-degree angle towards the heel, even standing.
Fascinating. Okay, the calcaneus, the heel bone. That axial view needs a massive angle, 40 degrees cephalic. Towards the head, why so steep?
It's all about the bone's orientation. The calcaneus sits quite vertically in the foot. To project its full length onto the flat IR, you need to shoot the beam almost parallel to the sole of the foot. That 40-degree angle towards the head does exactly that. It lays the image of the calcaneus out along the IR.
Where does the beam go in?
It enters the plantar surface, the sole, right around the base of the third metatarsal. And critically, the ankle must be pulled up into maximum dorsiflexion, a true right angle, 90 degrees between the foot and the lower leg. That gets the talus out of the way and ensures the whole heel bone is profiled.
40 degrees. Wow. And the standard lateral view of the calcaneus, much simpler.
Much simpler. Perpendicular beam. You center about an inch or 2.5 centimeters below the medial malleolus, that bony bump on the inside of your ankle. That puts you right over the subtalar joint just below the ankle joint itself. This view shows the height and shape of the heel bone nicely.
Okay, ankle time. This is where it gets tricky with similar names. AP oblique ankle versus AP oblique mortise joint. Big difference, right?
Huge difference. And a common point of confusion, let's clarify. The standard AP ankle is easy. Perpendicular beam right between the two malleoles, the ankle bumps. Foot pulled up to 90 degrees. Done.
Okay, now the first oblique, AP oblique ankle.
This one uses a 45-degree medial rotation.
Right.
Turn the whole leg and foot inwards 45 degrees. The specific purpose of this view is to open up the distal tibiofibular articulation, the joint where the tibia and fibula meet just above the ankle joint proper. If the doctor is worried about that specific spot, they'll order this 45-degree oblique.
But 45 degrees is too much rotation if you want to see the main ankle joint, the mortise, clearly.
Exactly. You hit the nail on the head. The ankle mortise is that socket formed by the tibia and fibula, where the talus fits in. It's made up of the tibial-latellar joint and the talofibular joint. To see that space open without any overlap.
You need less rotation.
Much less. Only 15 to 20 degrees of medial rotation. That's the magic number for the mortise view.
Why 15 to 20? What does that specific angle do?
It rotates the ankle just enough so that the intermalleolar plane, an imaginary line connecting the tips of the medial and lateral malleoli, is perfectly parallel to the image receptor. When that plane is parallel, the X-ray beam goes straight through the joint space.
And you get
A beautifully open mortise joint. No overlap of the tibia's anterior tubercle over the fibula, no overlap of the talus. It's the absolute key view for assessing ankle stability after an injury. That 15-20 degree range is probably the most important angle in routine ankle radiography.
Got it. 45 for tib fib, 15-20 for the mortise. Finally, AP stress views of the ankle. Sounds painful. Why deliberately stress an injured joint?
It does sound counterintuitive, doesn't it? But it's a highly specialized view. You only do it if you strongly suspect a ligament tear, usually after a bad sprain like a severe inversion or eversion injury.
How is it done?
The radiographer, or sometimes a physician, carefully but firmly forces the foot into either extreme inversion to test the outer ligaments or extreme eversion to test the inner ligaments. You take the X-ray while that stress is being applied, often holding it with tape or a special bracket.
And what tells you if a ligament is torn?
You look at the joint space on the side being stressed. If a ligament is ruptured, it's not holding the bones together anymore. So under stress, the joint space will visibly widen on that side. It's a dynamic proof of instability. That widening is the diagnosis, essentially.
Okay, moving up the chain to the leg. Tibia and fibula. Seems simpler than the foot, maybe, but there are strict rules about getting the whole bone right.
Absolutely. It's the classic long bone rule. Any image of the leg must include both the ankle joint below and the knee joint above. Always.
What if the leg's too long for one image receptor?
Then you have to take two overlapping images and stitch them together digitally, or just provide both views, ensuring the anatomy isn't cut off. Especially in trauma, you can't risk missing a fracture at one end that's related to an injury you see in the middle, or vice versa. Mandatory inclusion of both joints.
And for good AP view, how do you make sure it's not rotated?
You position the leg so the femoral condyles, those bumps at the bottom of the thigh bone at the knee, are parallel with the IR. That generally aligns the whole lower leg correctly. For the lateral leg view, you want a true side view. The key is the patella, the kneecap. It should be perfectly perpendicular to the IR, and the femoral condyles should be superimposed on top of each other. Center the beam right at the midpoint of the leg shaft.
Okay, the knee. This feels like where things get really complex, especially with that AP view. You can't just aim straight down. There's some kind of measurement involved.
Ah, yes, the variable CR angle for the AP knee. And this is probably one of the most uh, technically demanding parts of lower extremity work. It's
Mhm.
because the knee joint space itself isn't perfectly flat or horizontal in most people.
It tilts.
It tilts, yeah. And the amount of tilt depends on the patient's pelvic width and overall build. So to get the X-ray beam perfectly parallel to that tilted joint space and make it look open on the image, you have to angle the beam.
And how do you know how much to angle?
You measure the patient. Specifically, the distance from the ASIS, the anterior superior iliac spine, that bony point on the front of your hip down to the tabletops they're lying on. That ASIS to tabletop measurement dictates the angle.
Wow. Okay, so what are the angle categories based on that measurement?
There are generally three. If the measurement is less than 19 centimeters, so a thinner patient, narrower pelvis that the joint tends to tilt up a bit, you need to angle the CR3 to 5 degrees cadad towards the feet to match it.
Okay, thin patient, angle down. What about average?
If the measurement's between 19 and 24 centimeters, that's considered average. For these patients, the joint space is usually pretty horizontal, so you use a perpendicular CR. No angle needed.
And for larger patients?
If the measurement is greater than 24 centimeters, indicating a wider pelvis, the joint space tends to tilt downwards. So you have to compensate by angling the CR 3 to 5 degrees cephalad towards the head.
That is incredibly specific. Calculating angles based on body shape.
It's absolutely necessary if you want a diagnostically open AP knee joint. You can't just guess or use perpendicular on everyone.
Right. Now, lateral knee. The source says flex the knee, but there's a warning about how much flexion, especially if a fracture is suspected.
Yes, this is critical. Normally, for a standard lateral knee, about 20 to 30 degrees of flexion is ideal.
Why that amount?
It relaxes the quadriceps muscle, makes it easier to position, and it actually maximizes the volume within the joint capsule.
Yep.
It makes it easier to see things like joint fluid and effusion, or loose bits of bone or cartilage floating around.
But if you suspect a patella fracture,
Then you need to be extremely cautious, especially if it might be a transverse fracture straight across the kneecap. In that case, you should use no more than 10 degrees of flexion, maybe even less, almost straight.
why the limit?
Because if you flex the knee too much with that kind of fracture, the powerful quadriceps tendon, which attaches to the top of the patella, can actually pull the broken pieces apart. It can displace the fracture, cause more pain, and potentially make the outcome worse. So minimal flexion if patella fracture is on the table.
Good to know. And the CR angle for the lateral knee.
Usually about 5 to 7 degrees cephalad. That slight upward angle helps to separate the images of the two femoral condyles, projecting the medial one just slightly superior to the lateral one for a clearer view.
Okay, beyond standard views, the knee also has important weight-bearing options. There's a standard AP and then the specialized Rosenberg method.
Correct. The standard AP weight-bearing knee is straightforward. Patient stands tall, knees straight, weight even on both feet. It shows how the joint looks under normal standing load.
And the Rosenberg, how is that different?
The PA weight-bearing Rosenberg method is quite different. It's done PA, so the patient faces the IR, and they have to significantly flex their knees to 45 degrees.
45 degrees, why so much flexion?
It's specifically designed to evaluate the tibial plateaus, the top surfaces of the shin bone, and the intercondylar fossa, the notch at the back of the femur, under load. That 45-degree angle puts maximum stress on the cartilage surfaces in that position. It's particularly good for showing joint space narrowing from osteoarthritis, which might not be obvious on a standard or even a weight-bearing AP view with the knee straight. You see the cartilage loss best under that specific flexed stress.
Very specific purpose then. Now, let's go even deeper into the knee with the tunnel views, looking into that intercondylar fossa. We have three methods: Holmblad, Camp-Coventry, and Beclair. What's the goal, and how do they differ?
The goal for all three is the same. Get an unobstructed view right into that notch, the intercondylar fossa, at the back of the distal femur. You're looking for loose bodies, osteochondral defects, or fractures of the tibial spines which sit in that notch. But they achieve this goal using pretty different setups.
Okay, let's take Holmblad first.
The PA axial Holmblad can be done kneeling on the table or sometimes standing and leaning over. The key feature is the intense knee flexion, 70 degrees from straight.
70 degrees.
Yeah, that's a lot. Because the knee is bent so much, the fossa naturally points upwards, so you can just aim the CR perpendicular to the lower leg right into the back of the knee, the popliteal fossa. The flexion does all work of angling the anatomy correctly.
Okay, so Holmblad is max flexion, perpendicular beam. What about Camp-Coventry?
The PA axial cant Coventry uses less knee flexion, which is often easier for the patient. You flex the knee either 40 or 50 degrees, but because there's less flexion, you now have to angle the CR dramatically to match it.
Angle matches flexion.
Exactly. If the knee is flexed 40 degrees, you angle the CR 40 degrees caudad towards the feet. If the knee is flexed 50 degrees, you angle the CR 50 degrees caudad. It compensates for the shallower knee bend. Patient is prone, lying on their stomachs for this one.
Makes angle replaces extreme flexion. And the last one, Beclaire, is AP.
Right, the AP axial Beclaire method is the odd one out because this done AP, patient lying supine on their back. You flex the knee up so that the femur itself makes about a 60-degree angle with the tibia.
How's the beam?
Because the patient is AP and the lower leg is angled upwards, you aim the CR perpendicular to the lower leg. This projects the fossa downwards onto the IR, hopefully missing the patella. It's a good alternative if the patient absolutely cannot lie prone.
3 different recipes for the same result. Very versatile. Okay, moving on to the patella itself. We need tangential views to see how it sits and moves in its groove, right? Especially for tracking problems. 3 methods again. Houston, Merchant, Setagast.
Precisely. These tangential or sunrise views are crucial for looking at the patellofemoral joint space, the articulation between the back of the kneecap and the front of the femur. They show the patella in profile.
Let's start with Houston.
The Houston method is done prone, patient lying on their stomach. They flex the knee about 50 to 60 degrees. Then, to get the beam to skim under the patella, you need a significant CR angle, 45 degrees cephalad, angled up towards the head.
Prone, 50-60 flexion, 45 cephalad angle. Got it. Merchant.
The Merchant method is often considered more comfortable. The patient is supine, but their knees are elevated on a special stand or frame and flexed only about 40 degrees. Because the device positions the femur parallel to the tabletop, you can often just use a perpendicular CR, aimed down between the knees towards the patellofemoral joints. Needs special equipment, though.
Okay, 40 degrees flexion, perpendicular beam, needs equipment. And Setagast. Sounds intense.
The Setagast method involves the most knee flexion. The patient is prone again, and they have to slowly and carefully flex their knee as much as they possibly can, ideally until the patella itself is perpendicular to the IR.
Maximum flexion. Isn't that risky?
It can be. That's why there's a huge warning. You absolutely must rule out a transverse patella fracture before you even attempt the Setagast. Bending the knee that much could pull a fractured patella apart badly.
Right, we heard that with the lateral view too. So, rule out fracture first. What's the CR angle for Setagast?
It often requires a 15 to 20 degree cephalad angle, but it can vary depending on exactly how much flexion the patient achieves. You're trying to project that joint space open tangentially.
Okay, we finally arrived at the longest bone in the body, the femur. And because it's so long, you basically always have to image it in 2 parts, right? A top half and a bottom half.
That's exactly right. It's just too long to fit on a standard IR while also getting the necessary joint views. So you always do a proximal femur view, which must include the hip joint, and a distal femur view, which must include the knee joint.
Let's focus on the AT femur first. There's a specific rotation needed here too.
Yes, internal rotation is key, especially for the proximal view, to get the femoral neck and head positioned correctly. You rotate the entire leg and foot inwards by about 10 to 15 degrees.
Why that specific rotation?
For the proximal AP femur view, where the top of your IR should be right up at the level of the ACES, the hip bone point, that internal rotation, does 2 critical things. It places the femoral neck in profile so it's not foreshortened, and really importantly, it rotates the lesser trochanter mostly out of view.
The lesser trochanter being that bump on the inside edge.
Exactly. If the leg is externally rotated even slightly, that lesser trochanter sticks out prominently on the image. Seeing too much of it is a sign of incorrect rotation for a true AP proximal femur. So 10-15 degrees internal rotation hides it and profiles the neck.
Okay, internal rotation crucial for the top half. What about the distal AP femur view? Same rotation needed.
You still need internal rotation, but the landmark you're using to judge it changes slightly. For the distal femur, you internally rotate the leg just enough to make the femoral epicondyles, those 2 bumps on either side of the knee, parallel with the IR.
And you need to include the knee joint.
Absolutely. The bottom edge of the IR needs to extend about 2 inches or 5 centimeters below the knee joint itself. Got to see that entire articulation.
Makes sense. Now, lateral femur views. Getting a side view, especially near the hip with all that muscle and the other leg in the way, sounds challenging.
It definitely is trickier than the AP. And again, the positioning is quite different depending on whether you're doing the proximal or distal part.
Okay, let's do proximal lateral femur, including the hip. How do you get the other leg out of the way?
The main challenge is preventing the unaffected hip and thigh from superimposing over the one you want to see. So you have the patient draw their unaffected leg well back posteriorly. Then you actually roll their entire pelvis back slightly, about 10 to 15 degrees posteriorly, from a true lateral.
So it's slightly oblique.
The pelvis is slightly oblique, yes. That little bit of posterior rotation helps project the proximal femur you're interested in forward, free from the shadow of the other side.
Clever trick. And for the distal lateral femur, including the knee, is the pelvis oblique then too?
No, for the distal lateral, you want the pelvis in a true lateral position. The main adjustment here is flexing the affected knee to about 45 degrees.
Why 45 degrees flexion for the distal view?
That 45-degree bend helps relax the muscles, but more importantly, it aligns the femoral condyles correctly for a true lateral view of the distal femur and the knee joint. It ensures the anterior surfaces of the condyles are superimposed and shows the patella nicely in profile against the femur.
Okay, we've gone through all the setups, angles, rotations, a ton of technical detail. Now for the moment of truth. Looking at the image. How does the radiographer know they actually nailed it? What's the checklist?
This is where it all comes together, right?
Yeah.
Linking the effort to the result. If the image doesn't pass these visual checks, technically it should be repeated. Let's start back at the toes and foot.
All right, AP axial toes. What confirms success?
Two main things visually. First, are those IP and MTP joint spaces open? If yes, your 15-degree angle worked. Second, is there any rotation? You check by looking at the soft tissue outline on either side of the toe and the slight narrowing or concavity of the bone shaft in the middle. They should look equal on both sides. If one side looks thicker or the bone looks asymmetric, it was rotated.
Okay, and lateral toes.
Simpler. Is the toe truly lateral? The toenail should be in profile if it's normal. And crucially, is there any overlap from the toes next to it? There shouldn't be. Clean profile.
Moving to the AP foot, how do we know that 10-degree angle was right and the foot wasn't tilted on the table?
The check for no rotation on the AP foot is looking at the spaces between the metatarsals. Specifically, the spaces between the second, third, and fourth metatarsals should look roughly equal. If the spaces on one side are wider than the other, the foot was tilted medially or laterally.
And the lateral foot view, what's the key check there?
A really important one for the lateral foot is the relationship between the fibula and tibia down at the ankle. The fibula should overlap the posterior half of the tibia. If it's overlapping the front half, the foot was rotated incorrectly during the exposure.
Got it. Fibula behind tibia. Now, back to the ankle and that super important AP oblique mortise joint view, that 15-20 degree rotation. What's the visual proof it was perfect?
The absolute proof is seeing the talofibular and tibial-talar articulations completely open. That means zero, and I mean zero, overlap between the anterior tubercle of the tibia and the fibula, or between the superlateral corner of the talus of the fibula. If you see even a hairline of bone overlapping in that critical space, the rotation wasn't quite right, and you can't accurately assess mortise stability. It has to be wide open.
Crystal clear space is the goal. And for the standard lateral angle, besides the tibiotalar joint being invisible,
Again, check that the fibula lies over the posterior half of the tibia. Also, this view is your mandatory double check for a Jones fracture. Always glance down at the base of the fifth metatarsal to make sure there isn't a fracture line there. It's easily missed otherwise.
good tip. Moving up to the knee, all that fuss about the variable CR angle for the AP view. How do you know you picked the right angle, 3-5 down, perpendicular, or 3-5 up?
Success on the AP knee is all about symmetry. The space between the femur and tibia should look relatively even across the joint. The femoral condyles should look symmetric in size and shape, and that little pointy bit in the middle, the intercondylar eminence, should be perfectly centered within the fossa, the notch between the condyles. If it looks tilted or off-center, your angle was likely wrong for that patient's anatomy.
In the lateral knee, how do you spot rotation errors there? You mentioned the condyles.
Yes, the superimposition of the femoral condyles is your rotation check. In a perfect lateral, they should be almost perfectly superimposed. If you see one condyle projected significantly forward or backward relative to the other, it was rotated. A common error is over-rotation towards the IR. You spot this because the medial condyle, which is slightly larger, will appear closer to the patella than the lateral condyle. That difference tells you about the rotation error.
So the condyle position relative to the patella is the clue. Okay, tunnel views, Holmblad, Camp Coventry, Beclair. What's the universal sign you got the shot right?
For all of them, the main goal is an open intercondylar fossa. The notch needs to be clear, with no bone blocking the view. And specifically the apex, the pointy bottom tip of the patella, must not be superimposed over the fossa. If the kneecap is dipping down into your view, the flexion or the CR angle needs adjustment.
And for the tangential patella views, sunrise views.
Success there means the patella is seen clearly in profile, edge on, and the pelvofemoral articulation, the space between the back of the patella and the front of the femur, is open and easily visualized.
Great. Last one, the femur. That crucial 10-15 degrees of internal rotation for the AP proximal view. What confirms you did it correctly?
Two visual checks on the image. First, is the femoral neck seen in profile without looking shortened or squished? Good internal rotation achieves that. Second, look for the lesser trochanter. Ideally, it should not be seen sticking out beyond the medial inner border of the femoral shaft. Maybe just a tiny sliver is acceptable, but if you see that lesser trochanter clearly in profile, the leg wasn't internally rotated enough. It's a direct indicator of suboptimal rotation, meaning the view of the femoral neck isn't truly AP, and it probably needs to be repeated. Hashtag tag outro.
Wow. That was quite the journey from toes to hip. It really highlights how radiography isn't just point and shoot, is it? It's this incredible science of angles and positioning.
Absolutely.
Key takeaways for me. The sheer precision needed. That 10 degrees for the AP axial foot. That critical difference between 15-20 degrees for a mortise view versus 45 for a standard oblique. That whopping 40 degrees for the calcaneus.
And don't forget the simple things, like getting socks off.
Right. Don't let elastic ruin your image.
But if you zoom out, the big picture is really appreciating that every tiny adjustment the radiographer makes is deliberate. It's based on physics and anatomy. That whole calculation for the AP knee angle based on the ACES measurement, or knowing to internally rotate the femur 10-15 degrees, that's not arbitrary.
Adapting the technique to the individual.
Exactly. It's adapting to overcome the body's natural 3D geometry to get a diagnostically perfect 2D representation. It really is an exact science.
So that brings us to a final thought for you, the listener. We've talked a lot about how to check these images, open joint spaces, no rotation, specific overlaps. But think about the why from the clinical side.
Yeah, consider this. How does that radiographer's careful check making sure the fibula is perfectly aligned on the lateral ankle, or ensuring the mortise joint truly is open with no overlap? How does that seemingly small technical detail directly impact a doctor's ability to make the right call? To confidently diagnose that subtle ligament tear versus just a sprain, or to spot that hairline fracture that could be hidden by just a tiny bit of rotation.
That checklist isn't just ticking boxes, is it?
Not at all. It's the final quality control step. It's the safeguard that ensures the image provides the clearest possible truth about the patient's condition, directly influencing their diagnosis and treatment. The radiographer's evaluation is, in many ways, the silent, critical guardian of that diagnostic pathway.